Welcome to Morning Commute, exploring advances in acute myeloid leukemia, frontline care of patients with FLT3 ITD. In this episode, the rationale for more potent FLT3 inhibitors for AML. Enter quizartinib. Dr. Harry Erba and Dr. Justin Watts discuss the Quantum First trial and how these results are changing the treatment paradigm for AML. Morning Commute is developed by Projects in Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Daiichi Sankyo. Information about the faculty and disclosures can be found at morningcommutepodcast.com/AML3. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Erba is a professor in the Department of Medicine, Division of Hematologic Malignancies and Cellular Therapy at Duke University in Durham, North Carolina. Dr. Watts is an associate professor of medicine in the Division of Hematology and is chief of the Leukemia section at the University of Miami in Florida. I am your host, Candace Hoffman. Dr. Erba will begin the discussion.
Justin, welcome back. In our last podcast, we discussed FLT3 inhibitors midostaurin and gilteritinib. But now there's a new kid on the block, quizartinib, which is expanding our treatment capabilities, particularly for our older patients with newly diagnosed FLT3 ITD mutated AML. So let's dive right in. And let's recap what we discussed in podcast number 2, where we discussed the newly diagnosed FLT3 mutated AML patient and the current state of treatment landscape up to recently. Justin?
Sure. Hey, Harry, glad to be back. So the current landscape, and this is a bit of review from the last podcast, in younger patients with newly diagnosed FLT3 mutated AML, really includes 2 options: intensive chemotherapy with 7+3 induction, followed by consolidation and/or allogeneic transplantation with either midostaurin or now quizartinib. There are notable differences between these 2 FLT3 inhibitors. Midostaurin is a type 1 inhibitor and a first-generation FLT3 inhibitor. It hits multiple kinases, and its mechanism of action allows it to work on both FLT3 tyrosine kinase domain as well as the ITD mutation, because it's a competitive inhibitor at the ATP binding site. Quizartinib, on the other hand, is a second generation, so more potent and much more selective FLT3 inhibitor, and it's a type 2 inhibitor. It only works in the ITD mutation because it binds the inactive conformation and just completely shuts down the potential for activation of the receptor. Can't dimerize. So ligand dependent or ITD mediated constitutive activation is just turned off. In terms of the data, the efficacy data with midostaurin, this study was done, in only younger patients, less than 60 years of age, and again included both ITD and TKD mutations, the majority being ITD, but a significant percentage, around 20 or more percent, were TKD mutated. And this drug was approved in combination with chemotherapy based on a relatively modest but real and clinically significant survival benefit of about 7% or so, with long-term overall survival with midostaurin being around 50% and closer to 40% on the placebo arm. In terms of quizartinib and how that's changing the landscape, I will pass that one to you.
Thanks, Justin. I appreciate that. And we now have a second choice in the newly diagnosed patient with FLT3 ITD mutated AML. Midostaurin is still our go-to add-on drug to 7+3 and high-dose cytarabine consolidation for a patient with FLT3 TKD. But as you said, quizartinib is a type 2 inhibitor and only active against FLT3 ITD. the drug quizartinib was approved in combination with induction and consolidation and continued as a maintenance for up to 36 cycles, almost 3 years, in patients with FLT3 ITD mutated AML that was previously untreated. And that occurred in July of this year. So let's look at the Quantum First study that led to the approval. And in this podcast, I'm really going to focus on the efficacy and try to put the data in perspective to the old kid on the block, midostaurin, and how we might think about these drugs. So the Quantum First study was an international randomized phase 3 study looking at the addition of quizartinib as a 2-week course of therapy as a single dose each day, days 8 through 21, with induction chemotherapy, daunorubicin or idarubicin with cytarabine, followed by high-dose Ara-C consolidation with quizartinib for 2 weeks, again, 40 milligrams once daily for 2 weeks, and then continuation for patients who remained in remission. The primary endpoint of the study was overall survival. Now, what's interesting about the design of this study is that because it takes time to get back the FLT3 mutational status, the design was such that patients could be registered and a sample submitted at the time of diagnosis, but they could start standard 7 and 3 chemotherapy while waiting for the ITD mutational status to come back. And in fact, the largest reason for screen failures in this study was that many of these patients turned out to be FLT3 ITD negative. However, if the patients were between the ages of 18 and 75, with a FLT3 ITD allelic frequency of 3% or greater, they could be randomized to getting quizartinib 40 milligrams daily, days 8 through 21, or placebo. And they would maintain that randomization assignment through consolidation and continuation. During consolidation, patients could go on to an allogeneic stem cell transplant. And for patients over the age of 60, the dose of the cytarabine was during consolidation was dropped from 3 grams per meter squared for 6 doses to 1.5 grams per meter squared for 6 doses. Now, a major criticism of this study is that the control arm is not what Justin just told us was, what you just told us, Justin, was the standard of care, midostaurin. And that's because this study actually started as an international trial in 2016, about 6 to 8 months before the FDA approval in the United States alone of midostaurin in the same population of FLT3 ITD mutated AML. And so I was the co-chair of the steering committee, and we made the decision not to amend the study because this was an international study. It would have been hard to do, and many countries did not have midostaurin available. The other thing to keep in mind is study accrual ended in August of 2019, again, just 6 months after the approval in the United States of hypomethylating agents with venetoclax. So the options for our older patients were limited and may have contributed to the selection of patients who were over the age of 60 for this study. Nevertheless, the study went on. Primary endpoint was overall survival. What was different than about this study is that 40% of our patients in the study were 60 years and older. Most of the patients were from Europe and Asia. About half of them had an NPM1 mutation. And the primary endpoint of the study was met. The hazard ratio in favor of quizartinib was 0.78 for overall survival, with median survival of 15 months with placebo versus 32 months with quizartinib. Now, what's remarkable about this number, the hazard ratio of 0.78, is, as you said, Justin, that was the hazard ratio in the Ratify trial. But it's really important to remember that this study had 40% of patients who were over 60 that were not included in the Ratify trial, and only had the poor risk ITD mutated population, not the TKD mutated population. And still, there was a statistically significant improvement in the survival of patients with a 2-sided p-value of 0.03. And even if we censored at the time of allogeneic transplant, there was a benefit of quizartinib with a hazard ratio of 0.75 in keeping with the primary endpoint. And we're going to come back more to the benefit of transplant in this population in further discussions in our next podcast. But let's now turn to the response rate. And the response rate overall was higher with quizartinib than placebo. So the CRC, which included CR and CR with incomplete count recovery, was 72% versus 65%. There's no p-value on this estimate. But the CR rates were pretty identical, 55%. The reason for the higher CRC rate was a higher number of patients with CRI with quizartinib, probably due to the myelosuppressive effects of quizartinib contributing to the slower count recovery. But importantly, the duration of that CR was 3 times longer with quizartinib than placebo, 39 months median versus 12 months. And relapse-free survival was more favorable in the Quantum First study in the quizartinib group with a hazard ratio of 0.6, again with a tripling of the median relapse-free survival from 14 months to 39 months. If you look at the cumulative incidence of relapse in CR1, at 2 years, it was 31% with quizartinib versus 43% with placebo. Now, putting this in perspective to the RATIFY trial, the cumulative incidence of relapse in the entire group of patients in the RATIFY trial was 40% at 2 years, so higher, and that included patients that were younger and with the TKD mutation as well. If you look at the hazard ratio for survival in younger versus older patients, there was a clear benefit, especially in the younger patients. And in that population, the hazard ratio for patients under the age of 60, the hazard ratio was 0.68, so a 32% reduction in the risk of death in patients under the age of 60 with only the ITD, compared to a 22% reduction in the risk of death for both ITD and TKD mutated patients under the age of 60 in the RATIFY trial. However, something to keep in mind, and I'm going to turn this back to Justin in a second to address, is we still have a problem in older patients. And the hazard ratio is 0.9 for patients over the age of 60 in favor of quizartinib. And the benefit, if any, it was not statistically significant, but the benefit that may have been seen with quizartinib was clearly offset by a higher rate of early mortality in the first 3 to 6 months with quizartinib compared to placebo in patients 60 and older. And so, although it's very difficult to do this analysis comparing 2 studies, we're not supposed to do that. They both had the same control arm in terms of treatment, placebo, but they were very different in patient populations. And I think when you really compare apples to apples in these 2 studies, there's clearly a signal for efficacy with the addition of quizartinib to 7 and 3 and high-dose Ara-C, and then continued as a maintenance. So with that detail on efficacy, I'd like to turn it back to get Justin's thoughts on, what should we be doing for older patients? This study included older patients. They may not have benefited as much. It had a longer maintenance period too. So I'd like you to talk about the role of maintenance in AML.
Sure. Thank you, Harry. There's so much to dig into here. I think what you just said about comparing the 2 studies, obviously, that's not ideal, but we don't have any other options right now. So you can't just ignore the data. And I think what you said about the control arm is very true. And I think that's further supported about them being very similar, almost identical, in that the outcomes in the control group on both studies were very similar, with about 40% or so long-term survival, maybe a few percentage points better on the Quantum First trial, but right around 40+%. In terms of older adults, and this is probably the most important thing I think about these 2 studies and the differences, as you said, 40% of patients on Quantum First were over 60, and no patients treated on the Ratify trial were over 60. That's a huge number. And we know those patients do more poorly. They have higher early mortality, which we'll touch on, with chemotherapy in general, and possibly also with the addition of a myelosuppressive TKI. They have worse disease biology in terms of clonal diversity, co-mutational burden and types of mutations. And the FLT3 ITD, at least, may be more likely to be subclonal and not the only driver leading to different mechanisms of resistance that may emerge, as opposed to a younger patient who may have the more classic kind of NPM1, FLT3, and DNMT3A mutation, for example, where, FLT3 inhibitors really add a huge advantage there, I think. And so it's just the fact that those older patients were in there, and we saw basically the same overall survival benefit, almost exactly the same on these two studies. It's incredible. And again, also we, the Quantum First only included the higher risk, as we know, ITD mutation. And when you look at, and you mentioned the hazard ratios, but when you just look at the curves and the kind of 4-year, kind of the longer term estimated overall survival in the under 60 population on Quantum First, it was 60%, right? Not 50, which was the entire population. And when you look just at the older patients, it was about 30%, and that was 30% on both arms, not statistically significantly different, although there may be a slight benefit. That being said, speaking of older patients, older than 60, I think the Quantum First trial proves that intensive chemotherapy is the valuable and probably the best option in the more fit patients in that age group, right? Because there is a chance to be cured, right? There is still a chance to be cured with or without transplant, obviously more likely with transplant. And so I think that's very important, because the alternative to a 7+3 plus TKI induction strategy in older patients, and again, midostaurin wasn't studied in that population, but it is, as you know, sometimes done. And there are some other older studies that did look at midostaurin in older adults. But the alternative is venetoclax and azacitidine based therapy. And typically that is just venetoclax and azacitidine or decitabine as the kind of standard approved frontline approach in older adults, regardless of mutation, but including FLT3 mutations. And we know that it is active there in terms of response rates, quite active, but that the duration of response and overall survival is not the same as the rest of the population. It's a little better than AZA alone, especially with TKD, right? The risk there is not the same. It's really the ITDs that have, median overall survival of 11 or 12 months, not the 15 months plus, kind of in that intermediate benefit group to Ven/Aza, with P53 being the worst and FLT3 and or RAS mutated being intermediate, and all the rest doing very well with Ven/Aza, with median survival of 25 months plus. And that's about half of the older adults. So Ven/Aza is an option, but if you have a potentially curable patient, transplant eligible, I think the Quantum First data supports its use in those patients, with the caveat that doses may need to be reduced. And there may be other strategies to mitigate toxicity there that we can touch on with the quizartinib. In terms of investigational approaches in older adults, gilteritinib is also approved in the relapse refractory setting for any age, right? So there are multiple studies looking at adding gilteritinib to Ven/Aza in that older adult population, and we'll have to see how that plays out and how that might compare to a 7+3 plus quizartinib approach in the ITD population. Lastly, in terms of the maintenance period, another significant difference between these two studies is the maintenance period, where with quizartinib, it was almost 3 years, and with midostaurin, I believe it was 12 months. And importantly, maintenance was allowed to continue after allogeneic stem cell transplantation on the Quantum First trial as well. And I think there are some very interesting data that we're going to touch on regarding the effect or benefit of transplant in the Quantum First study, as well as on Ratify. And on Quantum First, the impact of MRD, both post-induction in terms of overall survival as a surrogate for that, and pre-transplant, and the effects of maintenance, whether it's positive or negative, by MRD, by NGS for FLT3 ITD. So I think there's still a lot to chew on here. And I was just talking about transplant, so maybe I'll pass back to you now to discuss transplant in FLT3 ITD mutated patients.
Okay, Thanks. What I take away from that is the Quantum First study was the first trial to include patients up to the age of 75 in this randomized trial looking at a FLT3 inhibitor, and was still a positive study with the addition. And yet, though, many patients are not fit for intensive chemotherapy, and we really need to continue clinical investigation to come up with better options. However, I think the Quantum First study shows that if a patient is fit for intensive chemotherapy and you're thinking of a curative approach, the benefit would be with quizartinib in addition to intensive therapy. And in the next podcast, maybe we talk a little bit more about management of potential toxicity. Let's now move to the role of transplants. And I think it's generally accepted in definitely in the United States and probably most parts of the world, that if a patient has a FLT3 ITD mutation, that they should be considered for allogeneic stem cell transplantation in first remission due to the high risk of relapse. Now, that's not to say that FLT3 ITD has not moved into the intermediate risk, but as Justin said, as you said in a prior podcast, that is a subset of intermediate risk where I think most of us would really feel strongly about considering allogeneic transplant. And of course, this was done on the study. So we looked in this study, I asked the statisticians to show me the data for patients who ultimately were selected to go on to allo transplant in first remission, and those who did not get an allo transplant in first remission. You might remember from the Ratify trial, those who got a transplant in first remission had a great benefit from midostaurin. But they also showed that patients who had a transplant, it said outside of first remission, there was no benefit. So those would be patients who likely relapsed and then, got a transplant in second remission. In the Quantum First study, the patients who went on to get an allo transplant in first remission had a benefit from the quizartinib. The hazard ratio was 0.59. Now, quite honestly, the hazard ratio confidence intervals did overlap 1, but it went from 0.33 to 1.06. What I thought was really instructive is that in the patients who did not get a transplant in first remission, and I can't think of a reason why there might be a patient getting quizartinib versus placebo where the doctor would choose based on something of whether to get a transplant. So to me, this is important data that showed a benefit of quizartinib. And here the hazard ratio was 0.61. So a 39% reduction in the risk of death. And actually the hazard ratio, the confidence intervals around that hazard ratio did not overlap 1. And we saw then a benefit even in patients who didn't get a transplant, but importantly in patients who did. But it begs the question, as we brought up in the Ratify trial, what is the basis of this benefit? If the response rates are very similar between placebo and midostaurin or placebo and quizartinib in these two studies, why do we see a benefit of the FLT3 inhibitor in patients in both of these studies, especially if they went on to transplant, but in the Quantum First, even if they didn't go on to transplant? And so what we did in the Quantum First study is we collected peripheral blood or bone marrow on patients at the time of remission. And we assessed whether the FLT3 ITD was still present using a next-gen sequencing MRD assay. And if we used a cut point of 10 to the minus 4 with reduction in the FLT3 ITD variant allelic frequency, there was a survival benefit of achieving that regardless of the treatment. And that's important. This is the first time a prospective study showed that the MRD status actually predicted outcome regardless of which arm of the study they were on. Now, if you then look at how patients did if they got quizartinib versus placebo, the median FLT3 ITD variant allelic frequency was 0.03% with placebo and 0.01% with quizartinib. And that was that had a p-value two-sided of 0.02. So 0.02. So statistically significant. And importantly, more patients on the quizartinib arm actually had completely undetectable FLT3 ITD by this assay following the intensive induction chemotherapy. And you have to imagine that remissions may have become deeper over time. And so clearly there's a survival benefit with this drug, quizartinib, in addition to intensive chemotherapy consolidation and continued as a maintenance. I think the FDA approved quizartinib as a maintenance, even though there wasn't a re-randomization to specifically look at the role of maintenance quizartinib. Quizartinib is known to have single agent activity, and that may have impacted on the FDA's decision to approve quizartinib as a maintenance for up to 3 years to 36 cycles, compared to what they did with midostaurin, where they didn't approve it, even though the design of the trials was very similar. And when I look at the data from the RATIFY trial and the Quantum First study, I cannot explain away the survival benefit based on the percentage of patients who went to transplant in these two studies. It seemed to be very similar. So, I think what the RATIFY trial did was show us a proof of principle with a first generation, less potent, less specific FLT3 inhibitor. And the Quantum First now shows us that, yes, indeed, when you use a more potent and specific FLT3 inhibitor, you actually can get even deeper responses and better long-term survival than what would have been seen with a first generation drug. But there are other FLT3 inhibitors that are being developed. And Justin, maybe you would like to tell us a little bit about that.
Yeah, thanks, Harry. And just I agree with everything you said. I think the biggest take home for me is that, the study Quantum First again just confirms the role of allogeneic stem cell transplant with both arms doing better, right? Quizartinib or placebo if they got a transplant. And notably, with the addition of quizartinib, not only did the entire population do better, but even in patients who did not go to transplant, when you look at the curve, the survival curve censored for transplant, there was still a benefit to quizartinib in those patients, with I think the long-term survival around 40% or so. So there's still an impact, and I think that ties into both more and deeper MRD responses, as you alluded to, and there was also a slightly higher composite CR due to the CRIs, getting those deeper remissions early, and then also probably a second benefit from the maintenance period with kind of preventing relapse in the transplant setting or in the patients who did not go to transplant in a subset of those. In terms of other FLT3 inhibitors under development, probably the other one we all think of, or that first comes to mind, is gilteritinib, approved for relapsed refractory AML as a single agent. It's also been studied with venetoclax in relapsed refractory AML. But also, what about in the frontline setting, right? What about adding it to venetoclax and azacitidine? There has been very encouraging early work by MD Anderson looking at the triplet combination, showing very high response rates, especially in untreated patients, older unfit adults for the most part. And this combination, though, as we've seen them report out, there can be even more myelosuppressive activity than already seen with Veneza with the addition of gilteritinib. And so the dosing really has to be done quite carefully and monitored quite closely, and that's still being worked out. And I think how this might compare to a chemo-based strategy with quizartinib, we don't know yet. It's going to be very interesting to see out. We haven't touched much on mechanisms of resistance, and maybe on the next podcast we can touch there as well when we talk about safety. And there's one other one that comes to mind under clinical investigation. And I should also mention first, though, that there are also studies ongoing using gilteritinib, right, with intensive chemotherapy, right, which have not read out yet, but there's a phase 2 PRECOG study in the United States and a larger randomized phase 3 study. Both studies are randomized, but a larger randomized phase 3 study in Europe comparing intensive chemotherapy gilteritinib versus intensive chemotherapy midostaurin. So we'll see how those data read out as well. And I'll lastly pass to you to touch on franolinib.
Yeah, I mean, the other one, FLT3 inhibitor that's moving ahead or is in phase 3 study with intensive chemotherapy is crenolanib. Again, the control arm with midostaurin, so a current control arm, at least with another FDA-approved drug with midostaurin there. And we saw the early data that's been presented and published by Eunice Wang and colleagues. Looks very impressive. But again, we have to wait for the completion of that study to see the benefit. And of course, what we haven't talked about here is the downside, the toxicity. We touched on myelosuppression. There are other things to talk about. And I always say this to the fellows that I'm training, is that if you do not follow the clinical trial in how it dealt with dose adjustments and toxicities, you may not ever see the efficacy of the agent that they saw in that clinical trial. So obviously it's a double-edged sword, and we need to clearly consider how to manage the toxicity, because as you said, Justin, we're adding a drug that is myelosuppressive. So why don't we get to that in our next podcast? And with that, I think we'll say goodbye for now.
Very good.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/AML3. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming service, or download our Morning Commute app. Thank you for joining us today.